Order, listen to the question.
I wanted to ask about vaccinations. I've had flu vaccinations in my stomach that end up in big whelps. So my GP is scared of that. COVID vaccinations, no problem. Now the shingles vax, apparently there's a new one out. Is that suitable for ITP people?
Yes.
Because my GP can't find out.
Oh. Yeah, Shingrix. So there was a previous, what was it called, Zostavax, which was a live attenuated virus. And if you're on immunosuppression, it wasn't one you should have had because it can actually cause a Zoster-like illness. Shingrix is it's not a live virus. It's 2 doses. It used to cost $250 a dose, but now it's free if you're over 65 or I think indigenous or on immunosuppressive therapy. And it's much more effective than the previous vaccine in terms of whether it causes destabilization of ITP. It's a very difficult question. We know some vaccines, so the measles, mumps, rubella vaccine particularly can be something that appears to trigger ITP in children. In adults, I've certainly got patients who've had vaccines who've had a deterioration in their platelet count. But we looked at this with the COVID vaccine, and I'll put Phil on because he sort of coordinated that. But, we did look at this specifically because it was a question that, very much concerned us.
Oh, look, basically, don't be afraid of it. Is the summary. Even if it does associate with you having a slight fluctuation in your platelet count, it'll usually right itself back to where you were. Okay. It won't be another one of those serious worsenings.
Thank you. Okay. For the shingles vaccine?
Well, in general, when someone's only just had their spleen taken out, vaccinations are a lot less impactful at being able to create memories because a lot of those immune cells that usually live in the spleen have been recently removed.
Yes.
Over time, there are different areas of the body where those cells start to come in and then they're able to start to make those memories again.
Oh,
so that's part of the reason why maybe it's not so bad down the track. And definitely I don't think too many people have had a very recent splenectomy, but if you've had one in a long distant past, that's no reason not to have a vaccination. It's the other way around. Yeah, it's a reason to keep having vaccinations in order to keep jogging the memory.
Okay, thank you.
A lot of the time when people have a splenectomy for ITPs because medical therapy is not working, and it's very common to receive intravenous immunoglobulin just before surgery. And intravenous immunoglobulin is a soup of antibodies. So if you then receive a vaccination to prevent a common infection, the neutralising antibody to that infection will almost certainly be in the IVIG. And if you have IVIG then give a vaccine, you don't get a good vaccine response. So you should have it more than 3 months after IVIG.
Next question.
Just coming back to the comments about communication between specialists and fears that things are going to be missed. Do you guys have any thoughts on what the barriers are to those communication breakdowns and what could be improved to make that easier on patients in Australia?
Yeah, so you're talking about between different hematologists,
Well, specialists in general and GPs, health professionals.
Yeah.
Sarah?
Yeah, that is hard.
I think we've got a winner. Ding, ding, ding.
That is curly.
I think
But-
my health record is important.
Privacy legislation is designed to protect privacy. One leading clinician once said to me he'd never seen anyone die of lack of privacy, but he'd seen plenty of people die because timely communication of medical information is blocked by privacy legislation. Now, there's nothing we can do about that, but you know, we have to have signed consent to release information about a person. We can't just have a phone call saying, I want my information sent. If you want it done through formal channels like hospital medical records department, it's an incredibly clunky thing, needing written consent. You know, privacy legislation has got a lot to answer for, there are certain situations where it probably benefits people, but Jesus, in the health context, it's a real problem.
I actually also think there's a bit of stigma about ITP amongst some of our colleagues outside of the haematology world. A lot of GPs, for example, are quite afraid of it. They're very afraid of low platelet counts. They look at a platelet count of 22 and they go, oh my God, you better go to hospital, when 22 might be good for you. So I think engaging with more education amongst our GPs in our areas and in our communities might be another way of breaking down some of those barriers so that they understand that the goals of treatment aren't necessarily to get your platelet back up to 150. It might just be to keep you safe, you know, but they might still be thinking along different lines.
And adding to that, it's not just GPs, it's other hematologists. I mean, that's the crazy thing, isn't it? That here we are telling you that there's going to be hematologists who are just not going to have that experience doing ITP, of really recognizing a platelet count of 22 is actually okay. And I know there's some, you know, people in the room, I'm sure, would have similar experiences where he's seen a hematologist and, you know, might have, in a way, been over-treated in terms of, unnecessarily increased dose of steroids for prolonged periods. Not having that, I guess, experience of dealing with a lot of ITP patients, which I guess here on stage we probably have the luxury of having. So yeah, I mean, it is very difficult because here you are, you've seen a specialist who is meant to be an expert in blood, but and I guess in a way why Danielle's doing this, having a ITP register, and it's fascinating because I remember her telling me, when she tried to run this by a non-ITP hematologist, they were kind of almost insulted, would be the word. Yeah. I'm not sure. But basically said that, why do we need that for? And we're like, it's people like you who respond like that is why we do need one. Because you don't know what you don't know, unfortunately. Yeah.
And I think too, coming to that is increasing education amongst those guys, having the guidelines and putting the guidelines in front of GPs, etc. That they do, because it's peer reviewed, because it is it's not from TikTok. Let's just put that there, because it's. I can feel a TikTok move coming on. No, because it's published, it's peer reviewed, and GPs and other haematologists are going to go, okay, so this has been checked. This is authentic. You're not just randomly coming in and going, I saw this on TikTok and somebody told me I need to do this. So it's literature. So this information is authentic, and the more education, and unfortunately as patients, we need to educate those around us, which is some of the work that we're currently working on to help alleviate some of that onus on patients and onus on the caregiver. So send them our way, take a business card, throw it at them, and just keep throwing it at them. One day it'll stick. Give them the guidelines, show them the newsletters, and get them to register, or feel free to register them online. And then they start to receive all of the newsletters as well and all of the emails. Maybe? Shameless plug. Nobody died from privacy, seriously. Any other questions? Yep.
Thank you. Thank you for such a great day and all the talks. I have a question about the recent research because the presentation here talk a lot, educated us about like how ITP works and then how ITP works like for like in our immune system. Are there any research looking externally, like to find the root cause, such as some like environmental factors or the like a human like a individual's lifestyles contribute to this disease? Are there anything in common, like for example, like the COVID, the bushfire? Does those have some impact on to certain individuals to suffer from this kind of disease?
There's a lot of little snippets of data that come out from time to time after things like COVID infections or after COVID vaccinations. Not a lot of that information is very believable or very robust. Something that's really interesting that not a lot of people are aware of is there's really good data to show seasonal variation with the incidence of ITP. And what that means is at different times of the year, there are more new cases that pop up. And in France, for example, it's always just in autumn, and then late spring or something like that. And I suspect, and it's always been my suspicion, we always go to a meeting called ISTH in the middle of the year, and almost every year when I'm away, there's a lot more new cases of ITP around June. So I absolutely believe that there are environmental factors, probably through viruses and infections at certain times of the year that trigger the immune system. But why that would cause ITP in you but not your husband or not your neighbour, that's probably back to genetics, other things that are there's so many different factors that I don't think anyone really has figured that out.
Next question. Oh, Carrie. We're going a flat venue next to you guys.
My question is there any genetic research going on?
Absolutely. There's it was actually a lot more popular to try to look for some various mutations that might predispose to ITP, but it ended in a great big mess. This is about 10, 15 years ago. Where it might have a bit more legitimacy might be in the younger cohort, like kids that get ITP, because they haven't been through so many environmental stimuli or rounds of COVID or flu infections. But definitely having a genetic susceptibility to autoimmune disease, of which ITP is one of them, there are a lot of associations. Like there's this thing called HLA-DQ where people with celiac and thyroid diseases and sometimes ITP go together. So definitely there are some strong suspicions that there are genetic underpinnings. Do we have a panel of tests that we can just quickly run like that? Not quite. But definitely there are other cleverer people around that have looked into this, and the answer is not simple.
I'll just add one more point to the previous question as well. I think ITP is a disorder of the immune system. It's dysregulation of the immune system. So infections cause immune dysregulation. Genetic factors can cause immune dysregulation. I think seasonal environmental exposures can cause, it somehow interacts on the immune system and therefore someone gets ITP. But how these factors act on the immune system to cause dysregulation, I think is the focus of all the research. So it could be environmental, genetic, multiple things. So the link with the immune system, I think, is the key which we're trying to unlock.
Where was I going? I was going this way.
Thanks. Is there any clinical trials for pediatric patients?
None of us look after kids, but yeah. Need to ask the guy that went home.
Yeah.
I'm not
right.
aware of
Yeah.
any in
Right
Australia.
now, no. There aren't any in there. I haven't seen any on the horizon, but we can. Yeah. But we can keep in touch with Mum, and we can let you guys know if and when that happens.
One of the big recent improvements for the changes in PBS, though, is the restriction for TPOs for adults got removed. So now anyone of any age with the right disease can access TPOs, and that includes you, Macy, if the day ever came. Yeah. Whereas before, you had to be over 18.
Mm.
If there was any research, I mean, sorry to be saying this, but it probably in Melbourne.
Yeah.
Oh, leg day.
So I have a question about IVIG. So if you've previously had a reaction following IVIG, does that generally mean you're going to continue to have reactions if you have it in the future?
No, I'm sorry to jump in, but not necessarily. There are different types of reactions. So things like the headaches how many of you had a headache from IVIG? Probably. Yeah, look at all the hands go up. That kind of thing is more of a physical property, probably to do with the stickiness of the blood. And so if we drip it in slowly and you're well hydrated, often it's not so severe. But there's about, half a dozen different brands of IVIG now, and they all have slightly different preservatives. And people are reacting more in terms of an allergic way to the preservatives that are in them, which is annoying, but it also means if you react against one, just let your doctor know, and then we'll usually try a different brand or a different one. So, and we usually find one eventually.
Yeah, a lot of things are called allergy that aren't allergy as well. You know, as Phil said, the headache is it's a kind of physical. It's much more common now. We use 10% than when we in the old days we used to use 5% because it's thicker. There's because we're a lot busier, we tend to try and give it more quickly. So if it's a more concentrated brand, if it's given more quickly, you get the headaches. There is a specific type called aseptic meningitis, which is more of a really specific side effect. But yeah, so IVIGs are made in different countries, from different donor populations, different preservatives, manufactured in different ways. So IVIG, although we say the evidence for IVIG, we apply that across the board to say IVIG works. What the original research was done on a drug mostly called sandoglobulin, and I think that's one we actually don't have in Australia. But I think there are 6. I think there's 1 or 2 locally made, and I think 3 or 4 imported. But they're broadly similar in what they do, but they do have different ingredients, particularly side effect generating ingredients.
And the dose matters as well. So sometimes when we give a gram per kilo, which is the biggest dose one can give in one occasion, that tend to have higher chance of sort of side effects. So if you actually split it up over a few days in a way, that the trick we have of just reducing reactions essentially.
Awesome, thank you. I have a
worries.
second question. It's a bit different. So I've recently heard a term called immune modulating. So rather than trying to boost our immune system, looking at modulating, which I don't completely understand. But I've got ITP, but also subclinical Hashimoto's is sitting there as well.
Mm-hmm.
And I want to boost my immune system because I get sick all the time. Like if there's a virus out there, guaranteed I've got it the next day.
Mm.
But there's almost this fear that if I boost my immune system, it's going to boost the 2 autoimmune illnesses.
I could tackle this one. So my lecture, Hematology 101. Immune modulation just means that we're modifying the immune system or its response, right? So that's really all it means. So really, any ITP drug that affects the immune system is immune modulating, essentially. So we're not necessarily boosting it.
Usually the other way.
Use the other way.
Yeah, sorry.
Yeah.
Immunomodulation usually means suppression rather than enhancement.
Yeah. We're using a euphemism. We're trying to smash it.
There are a few interference and things.
Yeah. So all these new drug, particular BAFF, APRIL type class of agents now is, us really sort of, instead of napalm, so steroids can essentially kill all lymph cells, essentially. That's exactly what they do. They they just kill the lymph cells. We're now narrowing it down. So there was rituximab, which only targeted the B cells. And then there were things like the mycophenolate, which targets T cells a little bit more. Now we're going really specifically now that there are monoclonal antibodies that literally kill one type of T cells only, right? So we're talking about a really niche smart bomb that only kills a specific population, right? So really in trying to really, in a way, I guess, reset the immune system, right? Because, that's what we see. I mean, Rob mentioned before how some ITP patients have these other immune conditions, right? So it's very likely a problem of the naughty T cells that somehow that they've let one slip where they're now allowing our other immune cells to start attacking the thyroid gland, our platelets, and we're trying to find a way of trying to rein that back in and resetting it, right? Yeah. Now there's a lady here that's been waiting to ask a question right there. Yeah.
What is the lowest platelet? Can you survive with like 0 platelet?
Oh.
Well, most analyzers don't say give a platelet count of 0. They default to 1. I mean, I had a patient who had 3 successful pregnancies without ever getting a platelet count of more than 3. The obstetrician was the most worried, followed by me. Followed by the patient. And she'd had childhood ITP, splenectomy. This was back in the early. This was actually in the late 90s. So this was a long time ago, before a lot of the newer treatments were available. But platelet count doesn't say everything. ITP platelets are big platelets. They work very well. So a platelet volume is an important factor in how well platelets work. Not literally how well. It sort of is, isn't it? So big platelets generally work better than small platelets. If you have a platelet count of 10 and you've got aplastic anemia or leukemia, you're going to bleed a lot more than if you've got a platelet count of 10 with ITP, generally speaking. So the cause of platelet count does matter. I read once, I've never been able to put my finger on where, it was years and years ago, possibly also in the 80s or 90s, that you need a platelet count of 7. Yeah, and I don't know where it came from, but it's the quotes in my head, but not where it came from. And that's just to sort of stop little bleeding episodes in your vascular tree. But bleeding risk, it's not just platelet count, it's age. So bleeding risk goes up considerably as you get older, and that's because diseases of the vasculature, high blood pressure, atherosclerosis, things like that also increase. So those are things, if you've got high blood pressure, you've got atherosclerosis, diabetes, your bleeding risk goes up, considerably. So it's not just platelet count.
And in addition to that, I think it's also, from what I've seen, how quickly things are changing. So there are a lot of people with a platelet count less than 10 who just keep on keeping on without a lot of bleeding. They might bruise easily, but that's quite different to people when they're sitting with a platelet count of 200 and then suddenly they crash to 12 and they might bleed a lot. Somehow their body's just not adjusted to that lower platelet count. And there are a lot of factors behind that, but day in, day out, things change with the quality of the platelet, but also what we call the endothelium, and that's the lining of the blood vessels.
I'm slowly making way.
Thank you all for your presentations. It was a fantastic session right through, and the opportunity to ask questions. My question is probably the unanswerable one. It's in relation to managing side effects of treatments. Just a general question as to if you have any general advice as to how patients might be able to judge what is a reasonable level of side effect. I was brought up in an age where we were told to toughen up, and so we toughen up. And generally, we don't really know when to start complaining and when it's just good for us. any general advice? And do you have any observations to make?
Come to me. I like that. I like your approach.
I just start. I think I can be happy for the panel to. The first question that came to my mind. You're right. It's unanswerable. And the first thing I thought about when you asked the question is that people see orthopedic surgeons for hip and knee replacements, and usually the decision to operate is when the patient's disability is too much to bear, i.e., it impacts their quality of life to their daily routine too much, and that's the tipping point where they say operate. Now that varies from patient to patient. So, like, I'm just thinking, so when do you decide that the hip is too painful, you go for a hip surgery? That's unanswerable. It's very individualized. So I think the question you asked it's hard to explain, but I suppose if what you want to achieve in life, and that varies from patient to patient, level of activity, lifestyle, what you wish to do, traveling, and so forth. I think, so that's individual. So once you decide what level of activity or what life you want to lead, then you can decide whether this side effect impacts that sufficiently enough to report to your doctor. But it's very, often with new medications, we always go low, go slow, and titrate. So we start at the lowest dose and then titrate up if you don't have any side effects and gradually increase so that you won't get too many side effects with new drugs. But you're right. I think it's a multifactorial decision, and I think us as physicians are happy to discuss with you what your tipping point is, where you go, I think I need this sorted. But yeah, it's challenging. I'm interested to see what the panel think.
You got to tell us, though. You got to. I mean, the problem is you got to tell us. We congratulate ourselves on a great response to treatment, but unless you tell us your life's misery, sometimes despite we always treat with best intentions, but sometimes the treatment's worse than the disease. But unless we know that.
But isn't that in the questionnaire when we do it each time we go?
Yeah.
And we bloody answer.
Yeah. That's a trial, John. That's a
I really like when patients come to see me. I like it if they bring their next of kin, wife, son, daughter, because often they won't tell you, and the person sitting next to them will tell you the downside. So I often say, you often call someone, they'll come and walk in, and they're clearly sitting next to someone. I say, oh, is that your wife? Tell her to come in as well, because they'll often tell me what the patient won't tell me, or the patient will tell the nurse or the pharmacist. So as far as I'm concerned, everything's going hunky-dory, and then they'll tell the nurse or the pharmacist, this is rubbish, this treatment, I feel lousy. It's almost like they don't want to let the doctor down. We've all got such high expectations of what we're doing. You don't want to tell the doctor there's a downside to what we're doing. We really need to know, because there often are alternatives. It's often not one. It's not this treatment or nothing. It's often this treatment or alternatives. But unless we know, there are some side effects obviously that we pick up on blood tests. But for the most part, it's how you feel. Only you can tell us.
I was only going to say you have every right as patients to strive for finding a treatment that causes no side effects, where your quality of life is back to where it was, and it's our job to try to help you get there. I still remember when thalidomide was first listed for multiple myeloma, totally different disease, but the number of people who would just put up with that treatment with so many side effects, because you know what? There weren't a lot of great alternatives in that disease at that time. But fast forward to 2024, no one's on thalidomide anymore, right? And almost the same sort of thing with ITP, in the sense that we are now in an era where there are a lot more options than what there probably were for your pregnant woman with a platelet count less than 3. And it is our job to help you find something that you can live with without too many side effects, and hopefully zero. Yeah, that's our job.
Yeah, we've not succeeded if we've just improved your platelet count. We want to improve your quality of life, what you can do, and just putting the platelet count up is only part of the story.
And absolutely, I think if you're treating hematologists, it's just worry about the platelet count and nothing else.
They need to refer you to someone else.
Correct.
Like our website with the register.
Yeah. It's not how on message we are, but no, really, that's really, really important. I mean, I think quality of life and this disease burden is such a huge thing because you're living with this chronic illness. You know, it's not just a bloody number.
Yeah.
Really, you know, I think those here on stage are the converted, but we really do feel we've got to do it holistically. We're looking after all of you, not just the platelet count. So, yeah. So please tell us. Don't just.
Yeah, don't.
They're not mind readers as wonderful as they are. Hey, that's a good thing. When it comes to being a patient, that's a good thing.
We're going to get Phil to do a TikTok with the guidelines.
One of the things that I've noticed out here on the patient board is that fatigue has got the highest number of.
Yep.
Funny that.
Yep.
Any research to see what we can do about that? Because I think that's the most important part of the chronic disease.
Yeah, I mean, just having chronic inflammation or chronic immune turning over uses up a lot of energy and releases, we call them cytokines, sort of hormones that make us feel unwell, a bit like you're coming down with the flu. And so that, I think, is part of it. I mean, there's also the whole concept of platelets absorbing a lot of serotonin, less serotonin around when all the platelets are being destroyed really quickly. Maybe at the neurotransmitter level in the brain, there's a little bit less serotonin. And maybe that's a role for getting onto antidepressants or things like that if you're feeling that way. And I also think a really big part of something that might not be said out loud is this churning anxiety in the back of your head of what that platelet count's going to be. And that uses up a lot of energy too. It uses up a lot of brain energy. And I think that contributes a bit to the fatigue for some people.
Fatigue's increasingly, unlike the Irish thing, that research a few years ago used to be on sort of things you could measure really in a laboratory test mainly, but certainly the emphasis has very much shifted. So quality of life is very much part of all the ITP trials I've done for quite a while now. Unfortunately, we don't have a sort of, this is the drug for fatigue, clear. There's not a clear, I mean, Phil's just alluded to why we think fatigue might be an issue, but it's not absolutely crystal clear. It's also not crystal clear that things that put your platelet count up will necessarily fix fatigue. I mean, I guess the important thing is when you, particularly with the TPRAs, they put your platelet count up, but they don't deal with the underlying kind of antibody issue. And that's why drugs like TPRAs, people with ITP have a slightly increased risk of clotting as well as bleeding. And the TPRAs don't do anything about that risk, whereas the immunosuppressive drugs do lower that risk a bit because they target the underlying disease activity. So they do reduce the risk of clotting. It might be that those drugs would do more for fatigue, but they also have more side effects that might counteract the benefits on fatigue. So you're kind of getting into a bit of a out of the frying pan into the fire situation sometimes.
I do want to make a comment regarding, I think, the mental health aspects of a chronic disease. And this is where I think I wish was really eye-opening. I mean, in that survey, and I don't know Aussies in that first reiteration, but there'll be a second one, hopefully, but there was not an insignificant number of ITP patients who had fear of death. And the crazy thing is that when you ask anyone on this stage, are we worried about physicians in terms of our patients bleeding to death? The answer would be universally probably no, because it's actually exceedingly rare. But then, I mean, I've made it my clinical practice now to actually voice that, because I don't think that often you see or hear a hematologist tell you, hey, just want to reassure you, you're not going to, it's highly, highly, highly unlikely you're going to succumb to your disease, right? And just to give that very simple reassurance. And that study, I guess, when it came out, it has changed my practice. It made me more mindful. Words matter. To reassure the anxiety is very much real and very much, when you see a huge proportion of patients who are anxious about their blood counts, right? Because unfortunately, your GP's bloody harping on about it all the time because they're terrified when they see your numbers is in red. And then, you're perhaps the first hematologist you saw are crapping themselves at a count of 40. That unfortunately, that's your very first experience. And look, there is a bit of PTSD associated with that. I mean, you remember that shock from that doctor when your platelet count's 40. And you might be lucky enough to then meet a hematologist who later on done a journey where obviously have a much more comfortable and more experience in dealing with it. But that memory's not going to go away though, is it? That, you saw doctors who were terrified about your disease. So, that really has become a great, I think, component of my consults where really, how are you feeling? What are you afraid of? What in terms of, what are your fears of where you are up to? Are you sleeping well? These things I think are critically important.
And also, the GP, like I know his GP rang up and said, you've got an ITP level of 11, I think you should just go to bed. I'm terrified.
Right, yeah. So, and all those sort of things doesn't help the patients or us when we're trying to sort of think, oh my God, what have I told you? Jeez. These people are laughing because they know. They all know that feeling.
Well, I had a patient who was told to go to the emergency department with a platelet count 25, and I pointed out that's the best platelet count you've had for years.
Thank you. I think the best thing I learned, I learned for the seminar last time, and Philip was one of the speakers. And I think the one thing that we took away from that was basically treat the symptoms, not the number. And that's kind of how we've lived our lives since we've done that. And I think we've certainly tried to deal with, and that has definitely lessened the anxiety around blood tests and what's the number, she doesn't even ask anymore what the number is because she knows now she's feeling okay, and that's kind of what we took away from the last seminar was treatment.
How do you feel?
What's the number?
Well, basically kickboxing. I think she's going to do it.
Lots of sleepless nights waiting for that number, but now,
That's one of the changes that I discussed in my presentation was that there's no preset platelet count you have to achieve to continue treatment anymore. It plays exactly to that point that you could benefit independent of the platelet count. Yep.
And I think too, it goes back to the number, is that how many patients were feeling fine before they walked into the room and then they got their number and then went, oh. Like I know personally it's happened to me many, many times. I was feeling completely fine when I walked in the door until I heard the number or I've got a call from my GP going, oh, your platelet count is 27. How are you feeling? Oh, shit now. Thanks. Right.
She's like, damn it. She's like, oh,
yeah.
Why can't I get it up? She always says it's personally with the number. So now I've really redefined it, how this
Because it's more than just the number.
It is.
It's all, I mean, not just in terms of quality of life and all that, but even if we were to think about just paper, it's also the quality of paper.
Size.
And that's, I suspect, maybe
talking about
to some of the results that might be standing by.
I would claim the glory. It's actually the team that I told this board was come down.
Yes.
And I told them to come down. They usually do a baby, but